In America, getting sick is a financial event first, and a medical one second. But that's not entirely true. Because somewhere along the way, the system that was supposed to protect you became one of the most profitable industries on Earth. And the people paying for that profit are the people getting sick. Think about the last time you or someone you know got a medical bill. Not the estimate. The actual bill. The one that arrived weeks after the procedure, full of codes you didn't recognize, for amounts that seemed completely disconnected from anything that happened in that room. This is the experience of tens of millions of Americans every year. Medical debt is now the leading cause of personal bankruptcy in the United States. Over 100 million Americans are currently carrying some form of medical debt. Not because they were reckless, not because they ignored their health, but because they got sick. A single emergency room visit can cost thousands of dollars, even with insurance. A cancer diagnosis can cost hundreds of thousands. And insulin, a drug that has existed for over 100 years, now costs over $300 per vial in the United States. In Canada, that same vial costs around $30. Same drug, same molecule, different country, different price. That gap isn't an accident. It's the result of a system that was designed deliberately, carefully, over decades, to operate less like a public health service and more like a financial market. And to understand how that happened, you need to understand how the money actually flows. Because the money flows in ways most people never see. Meet Ethan. He's 31 years old, living in Phoenix, Arizona. He works as a logistics coordinator for a regional distribution company. He makes about $52,000 a year before taxes. It's not a bad salary. It's not a great one either. After rent, groceries, his car payment, and utilities, he has around $400 left at the end of each month. His employer offers health insurance, which sounds like a good thing. Ethan pays $210 a month in premiums for his plan. His deductible is $3,500. That means, before insurance covers anything substantial, he has to spend $3,500 out of his own pocket first. For 2 years, this works fine. He's young and relatively healthy. He barely uses the plan. Then, in the spring of his 3rd year at the company, Ethan starts having chest pains. He ignores them at first. Not because he's irresponsible, because he knows what the visit will cost. When the pain gets worse, he goes to the ER. The visit is 4 hours long. They run tests. They do an EKG. They determine his heart is fine. It was a stress-related condition, probably from overwork. 3 weeks later, a bill arrives. $4,800. His insurance covered a portion. But because he hadn't yet hit his deductible, most of it landed on him. Ethan doesn't have $4,800 sitting in a savings account. He puts $2,000 on his credit card. He sets up a payment plan with the hospital for the rest. Now, he has a new monthly expense, $85 toward the hospital, plus growing interest on the card. That $400 he had left over each month? It's gone. And Ethan is not unusual. He is the median American healthcare story. Here's the first thing most people don't realize about American healthcare. The prices you see on a hospital bill are not real prices. They are called charge master rates, and they are essentially fictional numbers that hospitals set arbitrarily high. A hospital might list a basic blood test at $400. Insurance companies negotiate that down to $90. Medicaid pays $30. And a patient with no insurance pays whatever the hospital decides to charge them, often the highest rate of all. This system, known as surprise billing, balance billing, and cost shifting, means that the most vulnerable patients frequently pay the most. And the numbers are staggering. Studies have found that hospital list prices in the United States are often 3 to 5 times higher than what Medicare pays for the same services. Some procedures are priced 10 times higher. Why? Because pricing in American healthcare is not governed by cost. It is governed by negotiating power. Large insurance companies have enormous leverage. They can demand discounts. But an individual patient, sitting alone in a hospital gown, scared, with no ability to shop around, has no leverage at all. There's a name for this in economics: a captive market. When you're having a heart attack, you don't negotiate, and the system knows that. This is the first hidden rule of American healthcare. The price you pay has almost nothing to do with the cost of your care. It has everything to do with who is paying on your behalf and how much power they have. There's a second force at work inside this system that most people never see. It starts with a question: who actually owns American hospitals? For decades, most hospitals in the United States were non-profit or government-run institutions. They had missions. They had community obligations. They were not perfect, but their primary goal was health, not return on investment. Then, something changed. Starting in the 1990s and accelerating sharply in the 2010s, private equity firms began buying hospitals. They bought physician practices. They bought emergency room staffing companies. They bought urgent care chains and radiology groups and anesthesiology networks. By 2020, private equity firms had invested over $750 billion into the American healthcare sector. And when private equity buys a hospital, it does what private equity always does. It looks for inefficiency. It cuts costs. It finds new revenue streams. That sounds reasonable on a spreadsheet. But in a hospital, cutting costs means fewer nurses per patient. It means closing unprofitable departments, even if those departments serve the most vulnerable. It means discharging patients faster, regardless of readiness. A landmark study published in the British Medical Journal found that hospital mortality rates increased by more than 25% in the 3 years following private equity acquisition. 25%. That's not a rounding error. That's a structural outcome. And the patients experiencing that outcome are not the ones making the decisions. They are simply the revenue source. Here's the second hidden rule. In a financialized healthcare system, the patient is not the customer. The patient is the product. The customer, the entity whose preferences actually shape the system, is the investor. To really understand how this happened, you have to go back to the 1980s. Before that decade, American healthcare was already expensive by global standards. But something changed when the ideology of market deregulation took hold. The argument was simple. Competition drives efficiency. Let the market work. So gradually, restrictions on for-profit hospital ownership were loosened. Pharmaceutical companies were given extended patent protections, allowing them to block cheaper generic versions of their drugs for longer. Insurance companies were permitted to structure plans with increasingly high cost sharing, shifting more of the financial burden onto individuals. And healthcare spending in the United States began climbing at a rate unlike anything in the rest of the developed world. Today, the United States spends nearly $13,000 per person per year on healthcare. The United Kingdom spends around $5,000, Germany around $7,000. Americans spend more, and by most measures, get less. Life expectancy in the United States is lower than in most peer nations. Infant mortality is higher. Chronic disease rates are higher. And yet the profits keep climbing. In 2022, the top 5 American health insurance companies reported a combined profit of over $35 billion. That is not revenue. That is profit. Money left over after paying claims. The pharmaceutical industry routinely reports profit margins of 20 to 30%. For comparison, the average profit margin for manufacturing companies is around 8%. These are not the margins of an industry focused on healing. These are the margins of a financial system that happens to use medicine as its product. Let's come back to Ethan. A few months after his ER visit, Ethan starts reading about his medical bill. He reads that the hospital he went to was acquired by a private equity firm in 2019. He reads that the ER staffing company that treated him, a separate company he never chose or agreed to, was also private equity owned. He reads that the bill he received included fees from 3 separate entities: the hospital, the ER physician group, the radiology company that read his scan. Each one billed him independently. Each one had its own deductible threshold, and each one was, at some level, an investment vehicle. Ethan didn't experience healthcare that night. He experienced a supply chain. And this is the deeper truth that most people don't allow themselves to sit with, because once you see it, it's hard to unsee. The problem with American healthcare is not inefficiency. It is not waste, or fraud, or bad actors, though all of those exist. The problem is that the system is working exactly as the financial logic requires it to. A market optimizes for profit, and healthcare, as a market, optimizes for revenue extraction from sick people. The sicker the population, the more revenue the system can generate. There is no financial incentive to prevent illness. There is enormous financial incentive to treat it, expensively, repeatedly, indefinitely. Prevention doesn't bill. Chronic disease does. And so the system quietly, structurally, tends toward the latter. This is not a conspiracy. There are no villains meeting in dark rooms. It is simply what happens when financial logic is allowed to govern a human need. Most people who interact with the American healthcare system leave it feeling like they did something wrong. They feel embarrassed about the debt. They feel guilty for not having a better plan. They feel like they missed a step somewhere. But here is what the system does not tell you. The confusion is the product. The complexity, the multiple bills, the surprise charges, the networks, the tiers, the prior authorizations, is not an accident of poor design. It is the design. Because a confused patient cannot negotiate. A confused patient pays whatever they are asked, and a system built on that confusion generates billions of dollars every year. Ethan is still paying off his ER visit. He's now 32. He avoids going to the doctor unless something feels serious, which means the next time he goes, it will probably cost even more. That is how the cycle sustains itself, not through malice, through structure. The people who designed this system are not cruel. They are rational. Rational within the logic of financial markets. They did what markets do. They found a captive need, and they monetized it. The question worth asking, the question most systems don't want you to ask, is this: should a human being's ability to survive illness depend on their ability to pay for it? Every other wealthy nation on Earth has answered that question. The United States is still pretending it hasn't been asked. And until that changes, Ethan will keep choosing between the doctor and the credit card. And so will millions of people just like him.